The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
The intensive care department worry about patient safety? It would seem a pretty obvious moral question. But safety is expensive, or lack of safety. Essentially, if hospitals are not safe, patients are hurt, clinicians will lose reputation, and hospitals will suffer increasingly, as we've heard, financial penalties. There are significant costs of not investing, and we've seen Obamacare in the US, which has already gone further down this path, which we seem to be following. There's some evidence trying to put a dollar value beside it. So we know that in the paediatric system, that a critical deterioration event adds $100,000 US to the ICU admission costs. Furthermore, there is additional evidence from the UK which produces a fairly similar number once you adjust for the pound versus the dollar. If you look at adult cardiac arrest, the costs are extreme, and if you accept the universally accepted threshold of 50,000 US per quality adjusted life year, resuscitation in this context does not actually make the grade. We know that serious adverse events are common, okay, maybe up to 17% of hospitalised patients. And there are complex metrics, and I point out that many of those metrics are things that impinge upon intensive care, such as CLABSI, okay, MRSA, bacteremia. And these metrics, applied at least in the US system and possibly soon in our system, will result in a reduction in remuneration to the hospital. And whilst I take Rob's point that 1% doesn't seem like a lot, 1% in an organisation such as mine, which has a $700 million year budget, is $7 million, which is a significant deficit. From the 1st of July this year, already, sentinel events will not be funded in public hospitals. There are compliance issues. So we must comply increasingly with national standards and with mandatory reporting. And there are 10 national standards, and in particular, or all of them are relevant to intensive care, but in particular, Standard 9, the Deteriorating Patient. There are also the ICHS key performance indicators. But do all of them, or any of them, actually improve patient safety? Now, Peter Pronovost has tried to answer the question, how will we know that patients are safer? And he's come up with 4 domains, which could be summarised as the frequency of harm, the frequency of omission, have we learnt from our mistakes, and do we have a safety culture? And I think this may be a useful framework that we could use even at the departmental level. Now, administrators want a return on their investment. They know that intensive care is expensive. What we need are proven cost-effective strategies. And ICU is at the forefront of patient safety, and we have a lot of data. Now, one potential investment is the ANZICS database. It's not cheap in terms of data collection, possibly having to employ someone to do it, as I do in my institution, fees to ANZICS, equipment, office equipment. It's a significant annual outlay. Nevertheless, there's been a significant dividend in my view. We know, thanks to the registry, that our standardised mortality ratios are improving. So we have data that's testament to the fact that our safety is getting better. Not only that, we've got data now that tells us about processes of care. So, for example, after-hours ICU discharge, which is a potentially modifiable risk factor for mortality. We've further redefined sepsis. We've got a much better understanding of risk and of individual unit performance, so we can identify outliers and possibly intervene. So I think the question is not if we should invest as intensivists or intensive care clinicians, but rather how. So strategies can be defined as being either proactive or reactive. Now, it would be probably more cost-effective to try to manage safety as much as possible outside of the confines of the intensive care unit. Now, I've been itching for an opportunity to talk about the airline analogy, so I'm going to slip it in here. If you note the harmony in the cockpit there, which is business as usual for the pilots, sadly this does not resemble my average workday. Perhaps a better analogy in my case would be the September 11 attack, when the terrorists were trying to wrest control from the pilots of the airplane. The average ward round has several MET calls, multiple referrals, phone calls, requests for potassium orders, other interruptions. And instead of the onboard computer saying terrain pull up, we have the shrill ICU monitor saying the SATs are low or the blood pressure's low. Jack Nance writes a lot about healthcare and the airline analogy, and in particular this thing called a collegiate interactive team. But what he really means is the pilot and the co-pilot can speak up for safety and can monitor each other. And that's great, except the pilot and the co-pilot are both qualified to fly the plane. In my situation, it's often just me at night in the equivalent of a single-seat aircraft that resembles a World War I biplane rather than a Dreamliner. So I'm not sure about carrying that analogy so far forward, despite the fact that there's been a valuable contribution by simulation. Well, what about rapid response? And I'm wary that I'm talking to the believers here, and I am a believer as well, but I also believe in getting paid. So if you actually look at the published data, it turns out, based on some fairly conservative estimates of costs, that as call rates go up, costs clearly go up. But the evidence for call rate versus mortality does not suggest a dose response. Do MET calls prevent ICU admissions? Perhaps. Perhaps not. Now, the college regards the involvement of intensive care in the hospital governance as being very important. Okay, it's part of IC-3, and when you do an accreditation visit, it's always one of the mandatory questions. This is because of our centrality in patient safety and our ability to help with governance outside of the ICU. So I think this is a very important investment in time and effort in advocacy that we should all do. Now, when I trained in intensive care, patients only got into ICU because they were critically ill, provided they weren't too sick. These days, we have a strategy of risk mitigation by admitting people to ICU or HDU. The trouble is that there's no funding in this country specifically for high dependency. We also need to get with the times because there are new disruptive technologies, some of them are on display outside in the trade hall, which will allow monitoring outside of the confines of the ICU. We should ask ourselves, by admitting people to ICU, do we always reduce the risk? Do we sometimes do harm? Well, education and training is certainly a key enabler to improve outcomes and safety. And in fact, simulation-based training has been shown to be cost-effective. In this case, with respect to CLABSI, a return on investment of 7 to 1. We've got bundles for CLABSI, sepsis, ventilation, in fact general care such as A to F. And there's mounting evidence that they work, provided we apply them. We live in an era of checklists, and this is Atul Gawande, who's probably the key champion of this. Do they work? Well, there's mounting evidence that they do work, and specifically in the ICU context. One area that probably hasn't received sufficient investment is end-of-life care. And increasingly the literature is turning to this. Perhaps we expend too many resources on people in the last year of their life and should think more about proactively integrating palliative care, including even palliative care rounds, into our ICU. Now, what about more intensivists to make the hospital safer? Well, as much as I'd like to suggest that that's going to help, the evidence is preliminary and at this point doesn't actually support that contention. One study did talk about patient ratio to intensivists and came up with a figure of 7.5, and interestingly, above or below that figure, patient outcomes were worse. One thing that is coming through is that fatigue is important, and emphasising continuity of care over fatigue does not improve outcomes. But we need more research on staffing models. At this point in time, with respect to nighttime intensivists, and I know some institutions do have them, and obviously it's going to be case mix and centre specific. Nevertheless, the evidence would seem to suggest that patients are either too sick or too well to benefit. Do we consistently invest in safety? Across the country, there's significant variation in the number of physical ICU beds per population and also in the number that are funded. Why? If you look at staff specialist, medical specialist ratios for intensive care to population, there's reasonable agreement in the medians, but again, there's lots of outliers. Perhaps even more interestingly, there's some variation in nursing ratios, and yet the ACCCN guidelines, you would have thought, would have largely regulated this. Now, many of us work in training units, but do we train specifically for safety? Is this another area where we haven't invested? And I challenge you, what evidence do you have, in particular scientific basis, for attesting that your registrars are competent to manage an airway or insert a central line? We live in an era of value-based healthcare, and that means on the numerator, not just patient outcome, but also experience versus costs on the denominator. Now, have we invested adequately in patient experience? And does patient experience matter? So, for example, the relationship potentially between sleep hygiene, delirium, and mortality. There are differences and similarities between the public and private sectors for safety. Now, neither the health funds nor the federal government ABF program will fund high dependency per se, and they won't fund risk mitigation by putting people in ICU just in case. But there are a number of other bodies that have standards, such as private licensing units, the college, ACCN guidelines, service capability frameworks by state, which are not necessarily uniformly applied across the public and private sector. Why? There are differences in geography and size. In fact, the tertiary units and the private units have something in common. They both have a higher proportion of elective surgical patients admitted to them. Whereas the rural, regional and metropolitan units have to contend with a much higher proportion of patients referred unplanned from the emergency department. Now, clearly there are going to be some investment decisions in safety that are relevant for those units. So, in conclusion, I think there is a moral imperative for us as intensive care clinicians to improve patient safety. And there's a lot that we can do. There's a lot that we know about it. We've actually got an enviable track record that we can be proud of. But in summary, though, I think there's probably some room for us to do better. Thank you.